So you dislocated your knee. Well, not really your knee. You dislocated your patella. This is a really, really common problem. It's very painful. We're going to talk about it all today. I'm Dr. Brad Weening. Welcome to Talking with Docs.
I'm Dr. Paul Zalzal. Stick around to the end because we're going to show you how can you reduce it. How can you get your patella back in joint at the end of the video on your own. Dr. Deacon, welcome.
Thank you.
Okay, so let's talk about it. The patellar dislocation. Let's start at the beginning. Who gets it? How does it happen?
One of the most common traumatic knee injuries in a young individual, the most common is an adolescent, usually a female. They've got a story of some type of twisting force on the knee when the knee is somewhat bent. The most common complaint would be dancing, going downstairs. It can happen also in soccer, football, rugby, any of the field sports, court sports.
I have personal experience in basketball. My daughter, provincials, dislocated on court when I was the coach. I can share how we dealt with that in the moment, which was traumatic for everyone involved. Okay.
Yeah. So normally what happens is the knee is a little bit bent. There's a force on it. They feel something shifting out of place, and the knee swells up very quickly. When you get a knee that swells up very quickly like that, that means that there's bleeding into the knee. So there's something damaged in the knee. In most young people, a quickly swollen knee is due either to a patellar dislocation or to an anterior cruciate ligament tear. And so you got to keep these uppermost in your mind. Some people, the kneecap will stay out. It'll stay out of place. It'll be very obvious. They'll see it sitting on the side of the knee. And most of the time, the kneecap goes to the outside.
Vast majority of the time.
Vast majority. There are some that go to the inside, very rare.
Yes.
So most of the people that we're going to see, or anybody's going to see, are going to be going to the outside. Sometimes it doesn't go back in place on its own, and some of these people end up in the emergency department, and we have to reduce it there.
Right.
And if you think of the patella and it's the joint it makes with the end of the femur, we call it a patellofemoral joint, but I mean, compared to like a hip joint, the patellofemoral joint is not very stable at all. This is not a ball and socket. This is not a hinge. This is entirely reliant on all the soft tissues around it to keep it in its spot. So that's why it's such a commonly dislocated joint. A hip dislocation, you need a car accident for that to happen. But a patellofemoral dislocation, you come down off a jump shot in basketball, and it can happen.
Right. And yeah, the joint's very shallow, so the kneecap kind of jumps the border and ends up in the kind of side pocket. And the reason that it hurts so much is a couple of different things. One, all those tissues on the inside have to be obligatorily torn in order for it to get all the way over there.
Right.
And then the cartilage itself can be damaged from that severe contact.
Right. So you have to tear the medial patellofemoral ligament. So this is a ligament. It's not very distinct. It's sort of more like a fan-shaped piece of tissue that goes from the inside border of the kneecap, so where your knees touch, down into the femur, the thigh bone on the inside. So you got to tear that when you dislocate your kneecap. Right. The kneecap sits in this shallow groove in the thigh bone, and like you guys said, it can move out of place. And the muscle is what really keeps it there. So the muscle gets damaged, the patellofemoral ligament gets damaged, and you have this kneecap that's out of place and now unstable.
So say it is stuck there in the moment. We'll deal with the acute situation. How does someone get it back in? Like I said, some might end up in the emergency room.
Yeah, you just gently extend the knee and it usually pops back in.
Right.
So the people all present with the knee bent and the kneecap on the side. It's usually pretty obvious. And you reduce it by gently extending the knee, sometimes with a little bit of pressure on the outside of the kneecap.
So when this happened to my daughter, I heard a shrill scream that curdled your blood, and I looked from the bench.
That was Brad.
That was me, and she was lying on the ground. Her knee was bent, and she was just holding it, looking at it. And I knew, actually, the minute that happened, I thought, oh no, she's dislocated her patella. And as I walked out onto the court, she was in a bit of shock. She's looking, and she's just going, help me, help me, help me, help me. And I looked, and you could see the knee is grossly deformed. So if you ever see this in real life, it's not subtle. The kneecap is way off to the side, and it's not supposed to be there. It looks really, really prominent. So I said to her, we have two choices. I said, we can get you onto a stretcher, get you to the hospital, they'll sedate you, they'll put it back in. I said, or if you want, it's gonna hurt, but I can just straighten your leg and push it back in right now. She said, just do it, because she's a tough kid. So we just quickly straightened it. I pushed the kneecap back. There was a short scream, and then the crowd was actually very shocked that I did this. So I had to explain, hey, it's okay, I'm coach and I'm a surgeon and I'm her dad, so it's okay. But it was hard for everyone to see, and then we took her off, and then I had to keep coaching, and we lost the game.
But there's something important to remember for everybody.
Yes.
In that it has to be done gently,
Yes.
and the person has to be relaxed. And the
Yes.
same thing about putting a shoulder back into place as putting a kneecap into place. Don't push
Force it.
don't force it.
Agreed.
Because if you do that, you can do further harm,
Yeah.
especially with shoulders. Kneecaps are really no different.
Yeah.
And so you need to have the person relax
Yeah.
Yeah.
to be able to do this. I can do it on the field. I do it on the field all the time.
Sure. In football.
But I need to really relax these people. And if I'm, feeling some resistance, I'll wait, give
Yep.
them a
Sedate
little
'em.
something, sedate them,
Exactly.
relax them, and then get it back because I don't want to do harm to the cartilage.
Agreed.
In the
I don't want to
absence
shear a
of-
piece of bone off.
In the absence of any sedation, just sing a song.
Sing a song.
I've had this happen where I was called to my son's son's high school baseball game. Dad, someone hurt himself. He told me what happened. I bet you dislocated his patella because he had a history of it. And by the time I got there, the ambulance had arrived.
Yeah.
And then just the act of transferring him onto the gurney,
Reduced it.
straightening his leg off of home, when they peeled him off of home plate
Yeah.
and straightened his leg out, it reduced on its own as he was
Right.
getting into the gurney. So
Yes.
Right.
it does happen.
Okay, so now the kneecap is back in place. What does the treatment protocol look like for this patient who has dislocated their patella that's now reduced?
So initial treatment is obviously pain control.
Okay.
Trying to get the swelling down, so icing.
Yep.
Probably the emergency department is going to do some initial immobilization. So usually they put you into one of these Velcro type splints. Those are all for pain control.
Okay.
And
That's
then
a critical point, I think, to take home here. This is not to protect your kneecap. It is not to help it heal. It is to help reduce your pain because when your knee bends, it hurts.
right.
Can you
And,
walk on it? Are you allowed to walk on it?
Well, in the first few days it may be too painful.
Right.
But then we should be encouraging these people to put weight on it and to weight bear quickly. Get in to see somebody who knows what they're doing, so a sports medicine physician or an orthopedic surgeon.
Yep.
And what we're going to do is we're going to get you out of the immobilizer as quickly as possible, usually within a week to 10 days. We're going to get you weight bearing on it as quickly as possible so you don't lose muscle and get you into physiotherapy. And physiotherapy may tape your kneecap to try and keep it tracking properly, maybe use a brace to keep it tracking properly. But early mobilization and maintenance of the muscle is the key thing. We do not want to immobilize you or keep you non-weight bearing for too long because you'll make the problem worse. You'll lose more muscle.
Also known as physical therapy. And in addition to this workup of the history, the physical examination, you will get an x-ray at some point. Hopefully the x-ray is done with it in joint. And the x-ray does not need to be done before to make the diagnosis. That's usually
No.
a clinical diagnosis. But you want to get the x-ray done to see if there's a small piece of bone that might have sheared off the kneecap or the femur in this whole experience that you've
Yeah,
had.
that's an excellent point, Paul. They should be doing it in the emergency department after reduction, and you're looking for a little fragment of bone. And then the question is, do you need an MRI? And I think most physicians would get an MRI of an acute kneecap dislocation, but usually most of the time it doesn't change the treatment.
Yeah.
If there is a piece, you're going to see it on the x-ray. That's when you have to do something.
That's my approach so far has been I get the x-ray if I see a little piece or anything concerning, then I get an MRI. I haven't got an MRI 100% of the time if everything's progressing well and the patient's doing very well and there's nothing I'm worried about on x-ray. But often we do get an MRI.
Important message about the brace, like essentially the second brace that you might get, designed to push that kneecap over, but this does not restrict your motion. So the goal of it is that you can walk in this brace, you can bend in this brace, you can do your physio in this brace. It is to facilitate your recovery. It is not to immobilize you. So say, with respect to the brace, how long are we wearing this brace? So say I want to go back to basketball before we've recovered, our pain's okay, our range of motion's okay, our strength is pretty good. When do you say, hey, I can go back to my sport?
So when you've had a kneecap dislocation, the chances of having another one go up dramatically.
Especially if you're young, right?
And these tissues, the medial patellofemoral ligament, they're going to take at least 3 months to 6 months to heal.
Right.
And so I would tell people for a year or two, if the brace is keeping your kneecap stable, you continue with it.
Okay.
So the big question then is what happens afterwards if you end up with chronic
So you've done it
instability?
2, 3, 4 times. It's
Right.
just you're thinking about it, it comes out.
Right. So,
Are there options?
Well, usually there are some predisposing factors in people, and this gets a lot more complicated, but usually these people have high kneecaps. Usually the groove is shallow that the kneecap runs in. There's a big distance between where the kneecap tendon goes into the tibial bone and the groove in the thigh bone. There's causes of the kneecap instability.
So essentially anatomical risk factors.
Correct. I call them architectural changes,
Okay.
right? And so these people may go on to have chronic instability. They need to see an orthopedic surgeon.
Right.
And there are some very good surgical solutions to this now that we didn't have 20, 30 years ago.
And essentially designed to lower the kneecap, potentially deepen the groove, strengthen the medial tissues. Those are the three
Well,
things.
yeah, so and reconstitute the medial patellofemoral ligament. That's
Right.
number one. Some people have too big a distance between that we call the tibial tubercle, where the patellar tendon goes in, and the groove, and we change that distance a little bit with some surgery. But yeah, there are some solutions. The bottom line is get to see an orthopedic surgeon if you have chronic instability, and that's more than 3 dislocations.
Okay.
Or sometimes people don't even go completely out. They just feel the kneecap going part of the way out. We call that subluxation.
Right.
So chronic subluxation, chronic dislocation, get to see an orthopedic surgeon.
I think the way to look at it is the majority of the time, if this happens to you, you won't need surgery. However, if you are one of the people that this does end up being a recurrent problem, the good news is there are surgical solutions available to you.
Right, much better than we had 20, 30 years ago, which is the good news today.
Yeah, it's all
Now you
about
know.
good news.
If you're a kneecap dislocator, have an interesting story, please share it with the viewers that follow the comments. If you like this video, please like and subscribe to our channel.
Dr. Deacon, thank you very much for sharing
Thank you.
your patella dislocation experience with us. And remember, you are in charge of your own health.
See you next time.